All right, let us pray. As we gather today, let us reflect quietly on God's presence with us now and always. Jesus calls us to be aware of the chasm in healthcare today, the disparity in care that results in worse outcomes for persons who are made vulnerable because they are unjustly kept outside the mainstream of community life. Jesus calls us to act for justice. He calls us to bring comfort and healing to those who do not sit at the table today. Jesus calls us to advocate for persons on the margins of society and to promote and defend human dignity. Committed to the beliefs that every person is a treasure, every life is a sacred gift. Bless our work to diminish the chasm of disparity and bring about greater justice and equity in healthcare. Bless our work and all those in our community who need our care. We ask this in the name of Jesus and the power of the Holy Spirit. Amen.
Amen. Thank you, Jen. And hello, everybody. Such wonderful, lovely faces in our group today, as always, frankly. Today's topic is race and healthcare disparities. And quite frankly, I think it's fair for us all to say that within the last 2 years, if we never thought about our health, we certainly, the events of the last 2 years that's ongoing has brought our health and the health of our society front and center. And while that's going on, and we, of course, maybe are now more attentive to things we haven't been before, it is fair to say that due to racism in society and the aftermath of racism in terms of living conditions and some social policies, that there's been enormous healthcare disparities for a very long time. And if you will, they were only further exacerbated by virtue of being thrust into a pandemic. So if all of us, of course, are feeling at a minimum inconvenienced, quite frankly, there are some who have been struggling to survive every single day. And there's been challenges and there's been successes and there's been some improvement. By no means by us focusing on this topic is to suggest that it's been forgotten or ignored entirely. But perhaps it is more acute now for us to realize disparities anywhere basically threatens the health of everyone, everywhere, quite frankly. And so to get us started, I was trying to find something that might be a good kickoff that kind of covers a lot of different topics that are related and at the same time could bring us into a focused discussion. And frankly, what I was able to find was something that began. I'm sorry? Hello. What I was able to find, quite frankly, was a work that actually goes back more than a year ago. It was at the beginning of the pandemic, and the PBS NewsHour was covering the topic of race in America. And they decided to tackle healthcare disparities, particularly looking at one of the hardest hit places initially at the beginning of the pandemic. And of course, that was the New York City area and New York healthcare. This is a relatively short video, only about 6 minutes long, but it will open up a number of discussion points for us to follow. So I'm going to try to bring that up first. I've had mixed reviews in terms of how these videos have gone. So if you do get a little bit of a somewhat fractured video, know that it's not you, it's probably me, but hopefully at this point it will run pretty smoothly. We have everything else turned off. This is the only thing, so hopefully
it might help also if watchers turned off their cameras. I think that helps Zoom keep up.
That's a good point, unless the problem is at the source, which could very well be as well. But that's a very good point. So let's give it a shot. The host has disabled my ability to screen share. Could I request some assistance from either Jen or from Kathleen?
Try it now.
Oh, I got it. Thank you. Can you see this screen at the moment?
Yes, we can.
Okay, I'm going to move to full screen in just a second.
COVID-19 is forcing all of us to live in new ways. But as Amna Nawaz reports, it is also exposing long-standing rifts in American society. This story is part of our ongoing series, Race Matters.
Officials have said over and over again, the virus doesn't discriminate. But the disparities that have long been part of our medical system in America are now leading to what some call a crisis within a crisis. Black and brown communities across the country being hit harder, in greater numbers, and with fewer resources to save them. For more on this, I'm joined by Dr. Uche Blackstock. She was an associate professor of emergency medicine at New York University. She now runs a consultancy firm called Health Advancing Equity and practices in urgent care clinics in Brooklyn, New York. Dr. Blackstock, welcome to the NewsHour. Start by just telling us about the patients you're seeing right now. What are they telling you? What are their symptoms? How sick are they?
So currently I work out of an urgent care clinic in central Brooklyn where the population is largely Black and brown. And we've really been seeing patients over the last 1 to 2 weeks come in progressively sicker, a lot with fever, cough, worsening shortness of breath, some even sick enough to warrant emergency department visits.
And are you seeing any kind of trend in their symptoms? Do you know that these are coronavirus cases?
They're absolutely textbook COVID-19 cases. I mean, down to the type of symptoms, the course of the symptoms, the onset of worsening of symptoms, every patient after the next coming in with the exact same story. It's almost uncanny.
You know, Dr. Blackstock, you had told me that before the pandemic even hit, you were worried that those same patients you serve in your community were going to be hit harder. Why is that?
For multiple reasons. I mean, even thinking about the testing criteria that was initially being used to determine whether or not someone had exposure to COVID-19, it included the person needed to have traveled abroad to one of the countries where COVID-19 was endemic, like Italy or China. Also required someone having to know someone who had tested positive. And what we knew very early on was that, there were communities that did not have access to testing. We had heard of celebrities and politicians having very easy access to testing and quick turnarounds. And these are communities that already carry very high chronic disease burdens like diabetes, high blood pressure, asthma. There are also high rates of obesity. And, these have all been tied into racial health disparities linked to structural racism. So it's already kind of made these patients and these communities more vulnerable to COVID-19, as we're seeing that these patients are at increased risk for developing very serious complications.
It has been studied and documented, as you just mentioned, that the racial bias in our medical system, not just in access to care, right, but in how Black and brown people are treated once they're in care. As the cases spread further, as people get sicker, how are you worried, or what are you worried will happen as a result of all of those institutional biases and how that'll affect your patients?
Right. And, what we already know, as you alluded to, is that when, Black and brown people interface with the healthcare system, they often encounter provider bias. So we know, and it's well documented, that their pain is undertreated or their complaints are minimized. So my concern is that when these patients present to emergency departments and hospitals in their areas with COVID-19 symptoms, that their symptoms may be downplayed or they may not be taken seriously. And we do already have the data to support that trend continuing to happen.
We're talking before the peak in New York has even arrived. What do you think your community is going to look like, those communities in which your patients live a week from now, or 2 weeks from now, or 3 weeks from now?
I'm scared. I'm scared that these communities are going to be absolutely ravaged and devastated by COVID-19. I mean, when I think about how each day last week, I just saw sicker and sicker patients. It was significant, and it was also terrifying. And so I do worry, and we already actually have some of the preliminary data out today in the New York Times that our poorer areas of the city, which are mostly Black and brown, have the heaviest number of patients that have been affected with coronavirus.
Dr. Blackstock, you of course have a family at home too. You have a husband, you have 2 young kids. I wonder if you can tell me how you're processing this right now, whether you're scared for your own safety or theirs.
Thank you for asking. I will readily admit that I am scared. I'm scared about being infected myself. I'm scared about bringing disease home to my husband and my two small children. I've had to have very difficult conversations with my family recently, including one with my husband the other night, where once I realized things were really shifting here in New York City, I said to him, there's a chance that I may not make it out of this working on the front line. And, I want you to know that I love you. I love our children very much. And just please make sure that they always know that their mama loved them. And so these are conversations that not just I'm having, but many of my colleagues are having with their families as well.
Thank you for sharing that with us, and thank you for the work that you do. That's Dr. Uche Blackstock joining us tonight from New York.
Thank you for having me.
I hope that came through a little bit. Could you see that at all, or? Okay.
Yeah, we could see it. It was a little stuttery, but okay.
Okay. We'll keep working. I'll try to find the best way to get it to work in a very smooth fashion. But thank you all for that. If you will give me 1 second. Okay. Well, you can imagine there's quite a bit to unpack, and I think you could probably see why I chose that particular video, even though it is more than a year old. Things have happened since that recording. As we know that we have we've had a vaccine come in. We've had parties throughout the nation become vaccinated, some not. We also then seen variants unfold in which they literally have, in some regards, hit with greater vengeance than the original disease. And again, bringing into question for us in many ways, if it's hitting all Americans hard, it's probably hitting those who have traditionally been underserved even harder. What I would hope we might have a chance to discuss, and I really want to invite all of you to feel free to chime in and share your thoughts on these matters, is that we may want to pull out some, we can call them discussion points, items that were at least touched upon during that video. Perhaps first and foremost, front and center, the idea how health disparities are linked to systemic racism. There are different examples. We can probably go through that and talk about it. Many of you may be able to cite some in particular. Another large bullet point would be healthcare information seeking behavior for those who are perhaps at greatest risk. Perhaps they also are at greatest risk due to reasons sometimes beyond their control, but also might be where healthcare is sought, where healthcare is provided. A history of distrust. Sometimes parties hear that there is a great deal of resistance to trusting anything that is being communicated regarding healthcare. In some circles, there is actually a strong reason why, not to say that it's valid, but in all cases. But there has been a history of some horrific things that we also covered in Sacred Ground that also speak to why there can be not an innate trust at the beginning of these things. And of course, the longer that parties are distrusting both the problem and the remedy, the longer it can fester. So we can talk with some detail about that. And I think one thing at the end is you probably could tell, and I saw the humanity in the doctor's comments, particularly as she looked toward her own interests and her own needs. And I'm not sure if it struck any of you. It struck me that many times we were seeing people being interviewed, particularly nurses and some doctors, is that we have really quite a diversity of healthcare providers, some of whom have very strong opinions about this particular challenge we have, this healthcare challenge. And at the same time, they also have their lives to live and their personal fears. And some have been on the front line from the onset, hoping that there'll be relief and hoping that parties will do what's necessary to help us get past this pandemic. I think knowing that they have personal fears and apprehensions is noteworthy and certainly worthy of us having some comments and conversations about it. And lastly, hopefully within our hour, we can take a look at how we may see, or maybe if we acknowledge that there are some healthcare disparities that are evident locally, and how has it kind of presented itself. Many of you probably are aware of many individuals who actually are in the crosshairs in like more than just once. And that San Diego is not, of course, exempt or immune from any of what's going on. So it would seem to me it might be fitting for us to close out our conversation talking about the local experiences as we see it. But with no further ado, let's have a conversation, a chat about healthcare disparities and perhaps what we know. Many of us, of course, covered this in Sacred Ground. And we know that these issues were also broached during Sacred Ground. But to the degree that healthcare disparities have been historical and they are kind of like the results of systemic racism, would anyone like to at least chime in on their points of view of where they see that to be the case, or perhaps has never stopped being the case? Please, Agnes. I think you're still muted. There you go.
I just unmuted. My career was not actually in healthcare, but very adjacent. In other words, I worked in hospitals during research, but clinical research for well over 30 years. And the things that stood out to me, because I was working in Baltimore, which is a majority Black city, is that what hit me particularly hard was that the rates of infant death and maternal death are ridiculously larger in the Black population than they are in the white population in this country. And I think it has a lot to do with disparities in healthcare. Children who are 15 and 16 and 17 years old delivering drastically premature infants because they have absolutely no prenatal care, that they have no not proper sex education in the schools. They obviously are not getting the sex education at home because their own mothers are only 15 years older than they are. So that it winds up with the United States having an appalling infant death rate compared with the rest of the developed world, with Northern Europe. And there is really no excuse for our having worse maternal and infant deaths than those other countries, Northern European countries, which all have better health care for 100% of their population than we do. And the same, it came through in what happened with COVID, but it's been going on for years and years and years before COVID ever appeared on the horizon. And it just needs more attention. It needs real help. And it helps that we have now more physicians and nurses who are minorities. But the doctor who delivered my daughter 54 years ago was African American. It's not that they didn't have the doctors even back then, but the healthcare just does not, and still does not exist for those populations, and something has to be done about it.
Thank you, Agnes. I'm looking around. We have more squares than normal, so if I miss you, please just unmic and feel free to speak.
I would just like to second Agnes on that, because I did work in maternal child health care at UCSD about 30 years ago. And those populations were always the ones that would come in more with no prenatal care, no prenatal care, just come in to deliver. And the only exception probably were Anglo women who had substance abuse issues. Otherwise, that was a highly, what do I want to say, a greater population that the people of color that would come in without prenatal care, definitely.
May I?
By all means, Diane.
Yeah, I was probably something that related but not direct because I'm not in the medical health. But recently I read this. I think you guys are all familiar with the film called The Big Short, right? The film, and the author is Michael Lewis. Recently there is an interview of him. What he said about the society is that we have a terrible, terrible public health policy. And we expect the private sector to taking care of, do the charity work. And I know those words was really resonating. And I think if we talk about disparity of, that's probably fundamental issues that our health system is sort of, you have to pay for it. You have to pay for your health care. Not really covered by everyone should have public. If you compare other countries, including so-called developing country, that public health is actually was offered to everybody. So I don't know if we consider the United States is the progressive country like other European country. But the public health or health system was really behind compared to those Northern Europeans, like Egner was mentioned that. But not just North European. If you look at Asia, you look at Japan, you look at Taiwan, they all have public health system. And government, well, it's very different system. So I don't know if what I said is that create kind of defer other questions or not, but that's what I want to share. I think that this is the fundamental issues of this disparity of the care.
Thank you, Diana. I believe, and it's actually a wonderful start to, I appreciate that we zeroed in on really some of the manifestations of what is really a consequence in our society of racism and having really different access to healthcare, and in some cases no access by some. And some of it is also the continuation of other factors, whether it's housing disparity or other challenges in terms of, I'll just use a couple examples that come to mind quickly. And while we as a society have done a lot in the last few years to remedy these, they still seem to persist. So many of you are mature enough to know that, and by that I mean that you've been around long enough to know that lead poisoning actually was one of the major contributors to a number of things along the lines of race being different. But in fact, parties occupying housing and in schools and the like, where they were just simply not attended to in time, where we found out after, even though we were looking as early as the 70s, as early as the mid 2000s, we're realizing, oh, this is what's been going on for this community for a long time. California actually, I think, is one of the trailblazers in trying to remedy where lead and other toxins have been found to be in places where kids and other people actually are. For many communities of color, and there's no monolith, of course, but in some places where there's concentrations of communities of color, You also may notice that there's in some cities or urban areas that if you look to see where the dumping of toxic waste has been, it seems to always be, quite frankly, higher ground, leaching down toward where parties live, um, and very near to communities. And in many ways, that old statement, living on the other side of the tracks, is a little bit of a death sentence for some, because of the type of things that actually, especially during our industrial age, was kind of like really pushing forward. And what do we do with our waste? Well, we just dumped it over there, for having generational challenges afterwards. But I think that's one of those things, if you will, for that to persist, even when we knew, even when we, as a nation, we had knowledge, it only persists because of institutionalized racism. And it is, some of that's being, of course, addressed now as we go through different generations, but and such a heavy toll has been paid. It's interesting as we most people are well-meaning, and there's most providers who are, especially if you talk about direct care, physicians and nurses are they're in their field because they care, and they tend to try to do really the level best for their patients. But you probably heard that the respondent in the video talked about institutional bias, even provider bias, in which when a person who may be different than them is complaining or expressing concerns about a medical condition, there's, they may take 2 aspirins, call us in the morning, it's nothing to worry about, etc. And, and I'm not in the medical field, but I'm acutely aware that many times parties actually get that they finally, maybe after waiting too long, but they finally do seek medical advice, only to be sent home and then to perish. That happens far too often in what should be one of the most advanced societies that's on this planet. So suffice to say that this is not an old problem. I mean, this is not a new problem, it's an old problem. And it is a problem that it is actually, some of the healthcare issues we're finding are extensions of basically our racist past, the fact that we sometimes reserve the better care for others, and then others get something, maybe nothing whatsoever. But it does continue. Now, this has an impact also on healthcare seeking behavior for those people of color in different communities. And again, not a monolith, but for many, that history of racism also impacts how people seek their health, where they seek their health care, and where and how. And does any of you have any comments that you might want to start us off on that category in terms of where people are accessing healthcare, and whether is that in itself part of the problem?
I could maybe say something. Sorry, it got dark in here. Here we go. One of the things I thought was interesting was sort of the ghettoization of healthcare, and isolating people to the healthcare based on, if you've ever done this, your zip code. If you put in a zip code, they're going to assign a doctor to you that's in that general area. And sometimes that's not the best served doctor for you. And maybe your area isn't so great. And maybe you're not getting the Beverly Hills, connection that you would if you put in 90210. So I think that's just a built-in institutionalized, just weird little thing that happens. But just also the way to make healthcare difficult rather than easier to access, and the neighborhoods, and getting out there, and it has to be like a grassroots thing rather than just happening. So that's some of those things were sitting with me.
Thank you, Kathleen. Anyone else?
I think that goes along with education too, because I think about that, like people who live in city heights and they have big families, but then they have grandparents that they want to make sure live in Rancho Bernardo, Poway area, up in North County area, so that their child can get a better education and maybe probably even better medical doctors and stuff. And so they have their grandparents living in there and buying a house in that area, but they still live in City Heights, but they want to make sure they get the better education, get the better medical assistance, because down in where their zip code is, like you said, Kathleen, they might not get the best thing. They might only get the family healthcare doctor, you know? And so when you were talking about that lead poisoning stuff, you know, I worked with San Diego Habitat for Humanity, and they stepped in, like you were saying too, Robbie. California did do a good job and helped the people that are in Sherman Heights area, which is where they pushed all the homeless people from East Village over to that side, you know, and then they were sitting out in their parking lot areas in their homes, but nobody would help the people, the residents that were living there with that lead-based paint, because that was just an area that was not a great area that the county thought of, but people did step up and did help those people and did go do that first to help them get that lead paint out, because their health issues, there were a lot of health issues that were coming about from the Sherman Heights area, and they couldn't figure it out. So, and it's just appalling to me. And on the flip side too, or on the other side, I think about how health providers don't do a good job with seniors. You know, it's like if you're 80 years old and you go in there and I've got this problem, well, and you're not really succinct in saying what you think the problem is, because you're in that generation that says, oh, they know best, that doctor. They just tell you to go home and take 2 aspirins and check in later, right? And I had this situation happen to my aunt, because she was 80 years old, couldn't, you know, had some symptoms, but it wasn't enough for them to hospitalize her, you know, and that's just sad. I mean, an 80-year-old person might have more get up and go than I do. And so the way they think of them as just disposable, well, maybe that's a little harsh, but it really made me mad. And so that's my comments on that. I don't have too many answers on it, but I just have been through that with my family and have seen it. Thank you.
Thanks, Jen. If I may try to also give a bit of a segue, I guess one thing before we leave the general topic of the historical disparities, I think we can also mention that sometimes it's interesting how sometimes when parties create unnecessary harm, particularly, and as one, if you're one support area actually begets another support area and then creates problems as cascades. An example is the Michigan community in which they changed the water treatment arrangement they had. I'm thinking, is that Ferguson, Missouri? No, that's Missouri.
Flint.
It's Flint. I knew it was another F. Okay, so it's Flint. And, you know, to me, I just found it amazing that all the due diligence of what we know in terms of how to make sure that everyone has clean drinking water, that for the sake of expediency and for a contract, an entire city was put at risk. And frankly, you know, left with no place to go, had to endure that problem. I think it's been remedied to some extent now, but had to endure that problem because their former approach of the source of water was being changed from them. As a state issue, that's the self-inflicted wound. But I would argue that would not happen if Flint had different demographics associated with it. In terms of parties having a chance to have advocacy for what they believe is in the best interest of them and their children and their neighbors. One last thing I'll just toss in here before we move to the next bullet point is the issue of even the uneven treatment that we have in our society of areas where there's both drug abuse and addictions is one where I think one can argue that, if you forgive me if I'm saying as if everyone knows this, but for many communities of color, some of the most pernicious, most harmful drugs known to mankind, and also, ironically, most expensive ones, were being introduced to these communities. And when you think about it, if this was to be a social experiment, there's only one result you'll get out of that, and that is an implosion within. So if a community is poor and the most addicted, expensive drugs are introduced to that community, more so than any place else, that actually wipes out that community in many ways. Insult to injury is that, but it's actually the right thing to happen, is that to also realize that how we treat addictions in society is now starting to pivot, that people are looking at addictions as part of the disease process that requires care and attention, as opposed to just simply a criminal process. My only point in raising that is that while there may be parties within any community that will prey upon other members of a community, I would say that the source of that harm, the source of the drugs, the source of the pernicious element always is coming from the outside in. Those who are providing that are not putting their neighborhoods at risk. So it's one of those things where that is also an extension of systemic racism, where the poorest communities are subjected to battles that others do not have to go through, until something like drugs gets out of control. And some of the things that we have seen that have been, well, let's just say heroin and cocaine and the like right now, when it gets to an epidemic level that's affecting everybody, it then gets the proper attention to realize that on some level we are dealing with not only trying to address the criminality of this, but also that the addictions require treatment. You're trying to make people whole again. But there's a huge disparity with regards to that, and that one actually took on a legal component, where the things that many people are sitting in jail for now, that they did in their teens, are now no longer a criminal act. I'm not saying that they should no longer be a criminal act. I'm not saying they should. I'm just saying that we can see the consequences of uneven treatment. The only other thing that I would say here is that our responder on the video also mentioned provider bias, meaning that at some point some things are played down or dismissed, a little bit as Jen was saying that, well, it should be fine, etc. And on some level, that speaks to whether is our healthcare system culturally competent enough to be able to understand everyone's communication style, how they are expressing things, maybe to what degree does one go to a doctor at some point, and to understand what's severe and what's not. And it's the challenge for all of us to be as culturally competent as possible. And so let's talk a little bit. We went to information seeking behavior to a degree, but one of the things that's a phenomenon that many of you are already aware of is that in certain communities, and often they may be communities that have been underserved, the go-to for healthcare is not preventative care. It's normally when there's a problem, go to where? Not everybody at once. Okay.
Emergency room.
Yes. The emergency room.
Emergency room.
Yeah. And so imagine over time that becomes the ethos of what one is supposed to do. That it overruns our emergency rooms, which just became truly chronically aware about this during this pandemic. But also all the preventative care, all of the advanced adjustments so that people do not become ill. There's such a strong need to have that handled, and for more parties to know what is, how to stay healthy, But my intention here is not to keep talking. My intention was to actually introduce that as certainly another issue that when parties are thinking about information seeking behavior, there's a lot of good information out there. There's reputable sources, but we need to make sure that almost all of our citizens have access to that information in the manner that it can be consumed. So,
you know, Robbie, like people who are diabetic, and you know, the problem is too with it is that some people don't have enough money to eat correctly, right? So it's easy to go to Taco Bell for $1 taco. I'm just making this, but instead of you're diabetic, you shouldn't be eating all that stuff and carbs, but you don't have enough money to go buy greens and things that you need to eat, right? And so how do we help those? I see that all the time too, even with some of my friends. Well, I got to do this, or I got to pay this bill, but I can't, you know, buy all this good food, because good food, nutritious food, is expensive, right? And
actually,
so
that's a great point. There are, and actually, I wish I said it, so thank you. Because there are actually, that speaks to some other things that happen in underserved communities. Some are food deserts, literally, that the access to quality, healthy food, one has to take a hike and go through many bus stops to get to where they need to go. You know, it is also well documented that in some of the poorest neighborhoods, the only thriving businesses that seem to always pop up are those that lend itself to liquor and alcohol, where people can, you know, become further narcotized, if you will. And of course, there's this whole phenomenon of smoking, which it seems to have, it doesn't have any racial distinction. It just hits everybody hard, but it hits some areas a little bit harder because you start having different chronic conditions being combined. And so it's interesting to see what things thrive in areas that are deserts. And you know, and for parties who are coming through such spaces, it's sometimes hard for them. It should not be hard for us to imagine that an understanding where they can find the best preventative care is not something that parties have access to, at least not as instinctively as the rest of us may.
I'm struck by the intersectionality of all this, just over and over again, how all of these factors communicate with each other and affect each other. So the nutrition, the food desert, the doctors with huge medical school bills, debts to pay, so they want to work in affluent areas. The epigenetics that, I don't know if you all remember the wonderful forum that Susan Forsberg did maybe a couple of years ago now about epigenetics, where she talked about how trauma in the early part of your life affects your health, and it leads to things like diabetes and anxiety and obesity. And all of these things come together. And a lot of it is to do with poverty. So it comes down to money. What are we willing to spend our government money on? Sometimes that's the biggest question.
I don't think it's just money. I agree with you, Penny. I was just about to say intersectionality, because if you look at economic stability, neighborhoods and environment, the physical space where people are living, education, we've mentioned all of this, food security, community safety and healthcare systems. It is also, I mean, it's not just money, it is stigma and discrimination, and that is prevalent. It's just persistent. And it is part of institutional racism, and it's educating the healthcare force. You know, you talked about whether providers have cultural sensitivity. They don't get much training in med schools or in nursing schools or even in public health about that. And so when you come to deliver healthcare, you are coming in with all of these preconceived notions about the people that you're treating. And that's really difficult, and it just keeps, it's very persistent. I mean, many of you already know that I work in public health. I work with people who are addicted to substances, heroin, opioids, well, heroin's an opioid, and also in maternal and child health. And this, going from North Carolina to California, I see a lot of the same issues happening. And training people, re-educating in order to serve these underserved communities better is incredibly important. And I think as a community, as a cathedral community, I think we also need to educate ourselves in person-first language and the way we refer to people with addiction or mental health issues. That could be a stepping stone to better understanding conditions that people are living in order to help mitigate them.
Thank you both. Well, this conversation is moving along very, very well, and thank you. If I may, just let's shift gears toward something that has happened with the pandemic and what it has created for us, sadly. And that is to take a look locally on how it seemed to have hit hard here. Where did it hit hard? Perhaps why is it still hitting hard in some areas? So among the things that I think we can maybe chat about, let's look at three of them. One, the demographics of the responders, which I find intriguing. I would love to hear your thoughts on it. I did see one news story that was kind of fascinating, but I'll get to that in a second. And then, of course, recognizing that during this pandemic, there have been some folks who have been on the front lines the whole time. Their jobs, their responsibilities, put them out there for us to actually continue and almost with life being unaltered in a dramatic way. That's because other parties have been kind of out there engaging the public. So there have been a number of fears, not just by doctors and nurses, but also by many other parties who are responding, and also within families, in which I recall, many of you probably recall that there was often when we first were trying to get our footing regarding this pandemic, that for parties who were living in, let's say, multi-generational households, only one person would be allowed to go out and get everything and bring things back, so that not to minimize the exposure of everyone else. And we know that particularly for our Latinx community, it actually took a severe hit early on at the beginning of this pandemic. And I can acknowledge that a few mayors have really kind of like modeled the behavior of what is needed and how can we get past this. But let's talk about here locally. Disparities that already exist, but now further, I guess, brought to the fore in light of working through a pandemic. Have any of you noticed that and not to say like I was living under a rock and I couldn't see all this before, but have you noticed that many times when we're talking to our responders that we have such a global representation of responders here in San Diego? Okay, maybe not.
Can you define what you mean by responders?
Oh, I'm sorry. In this case, let's use nurses and let's use doctors. They're responding to patients coming in. We are very much a multicultural city, and also many of our first responders who are bringing people to the hospitals, the EMS crews, et cetera. It is pretty much a pretty strong multicultural group, which, an array of concerns and thoughts and fears. And my only point in bringing it up is that I actually watched I think it was a news report, and forgive me if I have it wrong, but I think it was a number of Filipino nurses and it might have been the Filipino Nursing Society here, that was acknowledging how particularly impactful this pandemic has been on them. Not only just the monster hours, but the whole issue of trying to protect your family, trying to protect your community, trying to protect everyone, every patient, and the emotional toll of losing so many people. So it's these, this is not just, and from my vantage point of bringing it up, is that I know that this can be very personal for many people. It's not necessarily us looking at this as in the rearview mirror as like, wow, that was tough back then. It's still going on right now. And we are seeing documents where healthcare providers are actually quitting. Like when it got to the second variant, and that they feel that they're working uphill, and that some individuals who are getting sick now seem not to care about how many other people get sick. That was one of the things that was also kind of poignant. And we are losing a significant amount of talented people as well. Some of it just burnout. Richard, I see your hand.
We had a newcomer this morning. His name is Jesse, and he is a nurse at Rady Children's Hospital, and he works 12-hour shifts, and he has to deal with children who are dying of cancer, etc. So I note that hopefully Jesse will come back and be with us, and we'll call for us to reach out to him, more people to reach out to him. He was very pleased with the reception that he got this morning. So
Was that the young man with the
look
dog?
for Jesse. And
Yes,
he's a
yes,
Filipino.
Penny.
Yeah.
Thank you.
Yes, I talked with him too. This is Connie. It was Jesse's 31st birthday.
Oh.
And he said, I had to come today because I had 2 children die on my shift. And I couldn't help it. I couldn't save them. And I had to come here. And I never heard how he knew about us. But he did say when someone was talking to him about his dog, he said, my dog is a therapy dog, and it goes around on a cart, and the children tug its tail and pat it and dress it up and whatever. And it's a very happy dog. And I said, oh, you should have been here last week for Blessing of the Animals. And he said, oh, I read that on the Scripps website.
Wow. But he was bilingual. I think he was Latino.
Yes, he talked to me in Spanish, and he actually asked me, are these church for only white people?
Oh.
And so I said, everybody here is white. and this was at the coffee hour.
Right, right.
So yeah, so I told him he was welcome to the 1 o'clock, and he said, okay, I'll wait. And so he did waited, and he came to the 1 o'clock, but I guess he was tired. And by maybe half an hour after the service in Spanish, he left.
Yeah.
Well, he had worked a 12-hour shift.
Yes.
And so he got off at 7:30, 8 o'clock or something. And then, but I talked to him twice briefly. And, but I think he was really happy to be there. And I said, please come back. But my heart ached for him. It was his 31st birthday. He had two children. He didn't say babies, 2 children die. And I thought he was in the COVID ICU working.
I'm not sure on that. Yeah.
But it may have been just ICU. But I was so happy that he was with us today.
But what an illustration of your point, Robbie, about the pressure, the relentless pressure and sadness and trauma that the nurses go through. for his birthday and the 2 kids dying at the same time.
12-hour shift.
How do you keep doing that day after day?
Well, I think this is what has happened is that the healthcare workers aren't willing to work a 15-hour day or a 16-hour day for the COVID load, because they did that. And now 92% of the people in the hospital didn't get vaccinated by choice. And they are tired. Now, not that with the children, I'm not saying that with Jesse, but I have known nurses that quit. They couldn't do it anymore.
Well, and the other issue is that no new nurses are wanting to step into those new positions, even if it's $50 an hour. You know, that's another problem. We don't have any relief for the ones that are continuing to serve. My neighbor works on the board of directors at Sharp. Sharp Steely, and that's the problem they're having. And that's really sad. Even doctors are quitting because they just can't take it anymore. And it's really sad. I don't know what we do about that, all that.
My stepdaughter is also a nurse, and she has talked about also, you know, in terms of the people who don't believe they have COVID, and they're very angry sometimes. So she said a lot of it is, you know, you just end up taking in a lot of abuse too. So it's really.
Well, and while we're talking about first responders, I think one thing that became clear with COVID almost from the beginning is that we have a large underpaid workforce that is essential for the rest of us and who can never work from home. Think of all the grocery store workers, the truck drivers. There's a nationwide shortage of truck drivers at the moment. But those are people whose jobs are such that they can't work from home. And so they weren't able to keep themselves and their families safe before we had a vaccine and before they were able to get vaccinated. So that a lot of them worked under just the stress of not being protected at all, and people who were, some of them being deliberately obnoxious about wearing masks when they went shopping, and having to be polite to customers who didn't care about the people that were serving them, that were providing an essential service. And then there are all the people that take care of our buildings and our streets and pick up the garbage. And they had no way of working from home. They had no way of staying safe when the rest of us were staying home and staying safe.
Agreed. And well, I heard for whom the bell tolls, I heard the toll for a second. So we are running out of time, but certainly, you know, this has been a wonderful conversation, and certainly one in which we would expect no less, that the degree of compassion and concern and thoughtfulness from St. Paul's is self-evident. I think for all of us, particularly the hope is, and I'm quite sure we'll get past this pandemic, but there are some lessons learned. And among them, of course, would be of those first responders, of those individuals who have put themselves on the line, their heroism and their compassion should not be forgotten. And there might be some things we need to fix in our society as well in that regard. And also, frankly, that those who have been struggling before the pandemic are still struggling. So want to thank you for this conversation, the opportunity for us to put some thoughts on the table.
Robbie, excuse me, may I interrupt just very briefly? When you say that, it makes me think, and Penny, you probably know if this is true or not. if there is already a church community that is recognizing first responders, is that too much to put on our plate? Not sure. So just something to think about.
Yeah, I'm not aware of, there may very well be a church in the area that's particularly populated with first responders and therefore holding them up. I don't know.
Mm-hmm. And maybe there's a way to do that in an ecumenical or interfaith way too.
Yeah.
Well, maybe we can, people who are interested could talk about it. I apologize that it didn't chime in sooner about that. Thank you.
Thank you. Excellent point. And that's part of what Sacred Ground in Action is about, that we actually have conversations that hopefully lead to even further activity and actions that try to provide at least, if not more knowledge, maybe even a potential remedy to some things that we've discussed. Jen, if I may, could I ask for you to give us a parting prayer?
Sure. All right. Let us pray. Dear God, we want to thank you for being with us throughout this meeting. Your presence has been in this place from the start to the end, and we want to say thank you. As we leave this place, let us go out there and be the salt and light. May we put into practice what we have discussed and learned. Help us to make a difference in this world for the glory of your name. Lord, where we drifted and said things that do not bring glory to your name, we ask you to forgive us. In your son's name we pray, amen.